Good morning to those of you in Queensland and Western Australia, and good afternoon to everybody else. So just like to welcome you on behalf of ACTnet and the Australian Respiratory Council. I've got with me co-chairing Amanda Christensen, who I'll hand over to in a moment. So we're really excited to be presenting this today. So this is an opportunity to bring together some of our TB and public health nurses and hear about the great work that they're doing, and many of you are involved in similar work. So I was at a international meeting for TB about 4 or 5 years ago and had a great session on contact tracing from the nurses in the UK, and I learned a lot. And so I'm sure I'll learn about, in a similar vein, I'll learn a lot about this today. So just a very brief discussion about what ACTnet is, and then I'll let Amanda introduce herself and talk about the ARC. So ACTnet is the Australasian Clinical TB Network, and we're a fairly loose group of people. This group started out 6 years ago, and we try to bring together TB clinicians and researchers, and really just try and network and see how we can support one another in research projects and clinical work and educational activities. And we're very grateful for support from the Australian Respiratory Council, led by Amanda, which provides us financial support to make things like this happen. So I'll just go over to Amanda, just maybe Amanda may like to speak a little bit about ARC and then introduce our first speaker. Thanks, Amanda.
Thanks, Andrew. So hello, everyone. To begin with, I'd like to acknowledge the traditional custodians of the land on which I join you today, and that's the Camaragal people of the Eora Nation. I'd like to pay my respects to elders past, present and emerging. I would like to welcome everybody to today's session. To begin, I'd like to just say a few words about the Australian Respiratory Council. We're a Sydney-based charitable organisation. We fund research and project work and undertake advocacy activities to promote lung health and TB elimination within Australia and the Indo-Pacific region. The call today is coming at a very good time, because I'd like to share with you all the opportunity. We have put out a call for research funding. Each year we fund research projects relating to lung health, infectious causes of lung health and TB elimination. And we fund projects within Australia and our region. So if you're wanting to find out more information about some of the work we do, please go to our website or contact me. I'll put my contact details in the chat box today. But I would be very happy to hear from anybody to support the work that you're actually doing. And some examples of the project we do are we've developed with the University of Western Sydney, the Master of Nursing program in TB management. We're developing a 4th unit on TB screening and vaccination at the moment. We're funding some project work in remote in the Solomon Islands for remote people, and some top-end community information, education, communication resources. So if you have any project or research activities that you think would be relevant, please don't hesitate to contact me. I think that's enough for today, Andrew.
Thanks, Amanda. I should just note, because of the nature of this, we've got 3 speakers. We'll just change the order a little bit for the sake of IT reasons. And if you want to put your questions in the chat box, we might have questions or discussions about some of the topics at the end of each speaker rather than save them to the end, because it might be hard to coordinate that. So our first speaker is Carolyn Gill from South Australia. And so South Australia obviously been in the news for all sorts of reasons with tuberculosis these last few months. And before I approached Carolyn and her team, we're very aware of the issues in the APY lands. That's obviously in last week's maybe spread in other areas, but very grateful to have Carolyn presenting to us. She's a registered nurse in the South Australian TB Services, and she's a current Associate Nurse Unit Manager at the Royal Adelaide Hospital, and she also is involved in sleep disordered breathing as well. And Carolyn's got 2 decades of experience in respiratory medicine, as well as TB screening and vaccination, and she's been heavily involved in assisting with the management of TB in remote Aboriginal communities in South Australia. So thanks very much, Carolyn, for taking the time today. I'll hand over to you. I think my video may not be working, but we can see your screen. Thanks, Carolyn.
So hello, everyone. I'd just like to present a little bit of information about some TB outbreaks that we've currently had in the APY lands in South Australia, and just our recent visits to those areas to provide screening. Traditional owners of the country throughout Australia, that we are respects to them and their culture, and to elders both past, present and emerging. So the APY lands, just for a context of where they're located,
Carolyn, sorry to interrupt.
Remote northwest of South Australia.
Carolyn?
It's 103 square kilometres of land which has been a land right, and you require access. Yes?
We're having a little trouble hearing you. It's breaking up a little.
Yes?
Your microphone is breaking up a little. I don't know if you can get any closer to a microphone. I'm sorry to interrupt you.
That's okay. I'll try and move my iPad a bit closer.
Thank you.
Okay. So is that better?
Yes, thank
Maybe
you.
if I turn it up. Yeah, okay. So yeah, so the APY lands, just for context of where they are located, there's a little picture there, very remote northwest South Australia. Some land that has been provided to the Ngudu people through a Land Rights Act, and you require a permit to enter the lands. Now, due to an increase in TB cases in Aboriginal and Torres Strait Islander people, predominantly in APY and mostly in the communities of Pukacha and Pitjantjatjara, the SATB services arranged screening in these communities. There was a case notified in May last year, which was the first notified case on the lands since 2018. And then currently, in this current cluster, we have 14 cases. So to date, the SATB services have travelled to the APY lands on 4 occasions. Our first visit was December last year for contact screening of the close cases involved in some active cases that we're aware of. Our second visit in February was like a break of contact and reviewing of patients that were on treatment for both active and latent disease. Our third visit was a school screening visit to 2 communities, Pukacha and Pitjantjatjara. And our fourth visit, which was our largest to date, which is the community where the majority of cases of TB have been, Ngudu Health Clinic, which is the local health clinic there, has been able to provide and manage directly observed therapy to the patients that are on treatment. So our first visit was obviously for contact screening. We took 4 staff members, a TB consultant, 2 registered nurses and a radiographer. We left Adelaide very early in the morning and it's a long way. We had to fly to Alice Springs, then on a charter flight to a weight restriction on our flight, on our charter flight. So we're only allowed to take 10 kilos of personal luggage. And then our other consumables were included in the payload on the plane. We had to take heater blocks for blood sample, incubation. We had to take our tubosol, we had to take a small fridge, needles, syringes, things like that, laptops, Wi-Fi's to be able to remote into our database in Adelaide. It was a contact screening of close contacts, and that was arranged with the assistance of the Ngudu Health Council, and we were able to use their clinic space in Pukacha for this visit. They also were very generous in providing us with access to some other consumables for bloods and using their clinic fridge and specimen fridge and centrifuge. The screening protocol for this particular visit was tuberculin skin tests, IGRA or quantiferon blood tests, and chest x-rays. Sputum samples were collected if people reported coughs and were able to produce a sample for us. And we also collected routine bloods, complete bloods, liver function, electrolytes, and for baseline in case treatment was required at a later date for the people that we were screening. Second visit was our 3-month break of contact. We were there for a week again. Travel very similar, except we left a day early so we could utilise more time in community. The only real difference with our second visit was that we were very lucky enough to have an additional item to transport, which was our portable X-ray unit, which was provided through some funds from Hospital Research Foundation. Screening was as previous with the TST, IGRA and chest X-ray. And during this visit, we had an additional case of TB identified, which happened very late on the last day. And so we were quite in a bit of a hurry to get things organised before our charter flight was due to collect us at 3 o'clock and take us home. The third visit was our school screening visit. We went to 2 communities, Pukacha and Piplajara. We were there for a week and we had 2 teams. Both teams travelled via charter flight to Adelaide, with stopping first to drop off people for the Pukacha clinic and second stop at Piplajara. A couple of staff went through Alice Springs so that they could drive down with some extra supplies, and an additional portable X-ray unit which we loaned from Darwin so that we had a portable X-ray for both teams. Screening at the schools was just the TST skin tests with IGRAs and chest X-rays to be provided if we had any positive skin tests. IGRAs and chest X-rays were also provided as follow-up for contacts from previous cases that we had been seeing in both communities. And then BCGs were also provided in children under 5 years of age. We had a bit bigger groups that went this time. We had TB consultant, TB project officer, 2 registered nurses and a radiographer in Pukacha, and a TB consultant, TB registrar, 2 registered nurses and radiographer in Piplajara. Now, our largest screening to date was our 4th visit, or our recent visit, which was in July. We were on the lands for 3 weeks, and the major cases being in Pukacha is why that was sort of decided to be the community where we do our screening for those 3 weeks. SA Health, Aboriginal Health, Public Health were very helpful in aiding with logistics and community engagement prior to us arriving for this screening. Once again, the travel was the big thing, charter flight and commercial and driving. The screening protocol for the community screening was for tuberculin skin tests for under 5-year-olds with IGRA or quantiferon bloods, chest X-rays for over 5-year-olds. Sputum samples were once again collected if people reported a cough and were able to produce a sample for us. And for that visit, we had 550 people present to the community out of, I think it was, we had 700 screening that were registered as living in Pukacha. So 550 was a really good number. Out of this number, we also ended up with another active case, 16 latent infections. This is only to date. Now, a few of the challenges that we experience with working so remotely is obviously the logistics of getting the staff and equipment to the APY lands. And for the bigger community screenings, finding suitable venue to be able to conduct the screening in. Culture and language, undergone quite a lot of cultural training, and we always have a safety briefing before we get deployed up to APY lands. SA Health, Aboriginal Public Health have been very helpful in helping us with the logistics and also with the safety briefings, and also community engagement, getting the community aware that we're coming and organising for us to be safely in community. The other thing is translations into Pidginjarra. So we've got audio, written and video translations of TB information, skin tests, BCG information, importance of screening and the screening process. Now, one of the challenges for being so remote is the collecting and processing of the blood samples. So we had to learn to sort of be semi-lab technicians as well. The equipment, we had to take all of our... Now, because of the distance, we had to partly process the specimens so that they could be viable until they were arriving in the laboratory. They are incubated for 16 to 24 hours, and we spin them for 15 minutes before we refrigerate them. The samples were packed into a specimen fridge or esky, and we transported them back to Adelaide with the staff. For the first few visits, it was with the staff that were flying back, and they were picked up at the airport by the SA pathology people. During the larger screening, we had 2 airlifts organised per week, and the bloods were taken back to Adelaide. The airlifts were also good for us to get additional supplies into the area. Now, the X-rays. So the X-rays were conducted by our radiographer. She came along on all of our trips so far. First visit, the Ngudu Health Council, we used their X-ray machine. Subsequent visits, we've been able to utilise this very nifty little portable Fuji X-ray unit, as I said, which was funded through the Hospital Research Foundation. A second unit's being arranged to assist with the larger screenings. So that makes the X-raying of people a lot easier. And the images get sent directly to a computer, so the doctor can review them, instantly, which is really great. Now, the skin testing, that proved to be a bit of a problem. Obviously, there's 2 visits required for a skin test, one to give the skin test and one 2 to 3 days later to read it. This proved to be a bit difficult as people didn't always come back to the clinic. People tend to move around a lot between communities and also between houses in the community. So the Ngudu Health Council nurses and their Aboriginal liaison staff were very helpful in helping us locate the houses that people were living in, and either helping them with some transport down to the clinic so we could check their skin test, or we'd see them out on their veranda at their house and read the skin test there, or go to the school or the art centre. The other thing that we have been doing while we've been up on the APY lands is the BCG vaccination on children under 5 years of age. So we're very fortunate to have had our BCG information and aftercare information translated into Pidginjarra. I've got little pictures there of our forms that we've adapted. Also, our consent form has been translated as well. And we've been training the nurses from Ngudu Health in the administration of BCG also. I think there's probably about 300 children that we've yet to offer BCGs to, and I guess that's something that we will follow up on as future visits occur. Currently, we've administered 40 BCGs during our visits to the APY. Future visits we've got organised. We're heading back just in a couple of weeks for a week just to review patients which are currently on treatment for active and latent disease. Further visits are being arranged for next year, and they will be at 2 monthly intervals at other communities throughout the APY lands. The biggest challenges for organising these visits are the logistics of getting everyone and everything there, and also the cultural engagement with communities and organising for us to go to the different communities. I feel that we've had really good results and feedback so far on the visits that we've conducted, and hopefully that'll continue on in the future. And just a special mention to SATB Services team, medical imaging, SA pathology, South Australia Health, Aboriginal Public Health Department, Nanapa and APY, and also to the Irrawee in Adelaide for their cultural discussions and assistance with translation of our information that we provided to people on community. We had it running on a loop to the information before they came and had their screening done. The one I've got the link for is the English version. It has been done in Pitjantjatjara as well, but I think English would be best for this event. And hopefully it works. Can people see that?
Yes, we can see that.
Okay, I'll see if it works. Hopefully it does.
What is tuberculosis or TB?
TB is a germ that can infect your body, especially your lungs. It can make people very sick, but you can also fully recover if you take medication. Anyone can get TB. TB disease is very common in other countries.
What are the symptoms of TB disease?
The symptoms of TB disease can be different for different people, but can include a cough that lasts for more than 2 weeks, a cough with phlegm or blood in it, fever, chills or sweats, lumps in your neck or unexplained weight loss. Anyone with these symptoms should visit a doctor.
How does TB spread?
TB is not a fast-moving virus like COVID. It is a slow-moving bacteria. You can only get TB if you breathe in droplets of the germ from someone who is sick. This can happen if you have been close to someone coughing, speaking, singing or yelling in a closed space. For example, if you have been in a house, school or workplace with someone sick. But it doesn't spread in just a few seconds. It takes hours. It is also dangerous to share bongs with someone who has TB. TB does not live on surfaces like cups, tables or door handles. It does not get passed down through family lines. Although, family can get sick if they are living with someone with TB who is not taking medications. TB is especially dangerous for older people, children and people with other health problems like diabetes.
What is latent or sleeping TB?
TB is a bit sneaky. It can live in your body and you don't even know it's there. We call this sleeping TB. You can only catch sleeping TB from someone who is sick, but it can live in your body without making you sick. It is sleeping, like the desert frogs that bury themselves deep down in the desert sand and stay quiet for years. But, like when the rains come and the frogs pop up, the TB can wake up even years later. Then the community can get sick again. So, it is very important that we check if people have sleeping TB and give them medication to get rid of it.
How do you test for TB?
There are different ways to test for TB. If someone has symptoms of active TB disease, like a cough or fever, doctors will usually test their phlegm and perhaps do a chest X-ray. If we are checking for sleeping TB, doctors will usually use a skin test or a blood test. Because TB is sneaky, sometimes doctors need to do more than one type of test.
How do we get rid of TB?
If you or someone in your family has TB disease or sleeping TB, don't worry. There are medications that can make you fully recover. But there are a lot of medication to take for many months. People who are sick will usually need to take medications every day for 6 months. Doctors might organize for a healthcare worker to visit every day to help people take their medications correctly. It is very important that people take all the medications for as long as the doctor says. If they don't, the TB can come back and make the community sick. It can even come back stronger, so some medications stop working. This is why we need to support everyone who is sick to take their medication.
What if someone in my family or community has TB?
If someone is taking TB medication, they cannot pass on the germ, so there is no need to worry about being near them. There are people in community who have had TB treatment, and now the TB is gone from their bodies. The most important thing is to support our family and community to get rid of TB. If someone you know is sick, take them to the doctor. If they need medication, help them to take it all until the doctor says it's okay to stop. If they are travelling, talk with them and their doctor about how to get medications where they are going. If we do all of these things together, we will beat TB.
What is happening now on the APY lands?
Some cases of TB have been identified in the APY lands. SA Health and Nganamba are now working together to test people for TB disease or sleeping TB and to give treatment to anyone who needs it. If SA Health and Nganamba are visiting your community, please come out and get tested. Let's work together to get rid of all the TB in the APY lands.
Okay, so thank you very much. I hope that was useful information. We're having a really great time up there, so we're going to keep on going and visiting as many communities as we can.
Well, thanks so much for that. That was really terrific, Carolyn, and that was a great video. There's just we haven't got a lot of time for questions, but we'll just go through some in the box from Chris Coulter, who's in Queensland. I'm not sure if you're happy to answer these, Carolyn. Was BCG only given once these TST was known, or was it not required? And there was a second one from Lauren Deacon. I'm not sure if you can read that, about the IGRA test. Was it completed for those with positive TST results? You can answer for those, Carolyn?
Okay, so the BCGs, we did TST before and checked those. They were negative. There were some children that we just BCG'd, not a huge number, but majority had the skin test before. And what was the other thing about the IGRAs?
You mentioned the IGRA was completed for those with positive TST results. What was the protocol if there was a discrepancy between the IGRA and the TST?
So everyone on most of on our visits all had IGRAs, and obviously the TST being difficult to locate people to do the reading, at least we, if we couldn't do a reading, at least we had an IGRA result, and they're all followed up in Adelaide. So we anyone that's comes back with a positive IGRA will get assessed and offered treatment on one of our other trips.
Thanks. And look, we'll just go to 2 more questions, and then we might, if we have time, we can circle back to some of these because I'm sure they're applicable. One is from Catriona Furlong. How many communities are there in the APY lands? And also one from Marie Rays. Did you have any issues with community engagement? You've had 500 sounds like a lot in one community. What do you think the overall turnout was in terms of the total population? So maybe just briefly, how many communities are there you're trying to cover, and what percentage of the population perhaps did you cover?
I believe there's about 3,000 people that live on the APY lands.
And are you planning on? Sorry, keep going.
Yeah, and we're going to be going to the various other communities. The reason we've been sort of focusing on Pukacha and Piplajara is they're the two communities where the active cases have been identified, and Pukacha is one of the larger communities. There was about 700 people that were registered through the health service there that were on our books, I guess, to offer screening to when we were there for the community screening. So the 550 that came was a wonderful result. The other communities obviously are a little bit smaller. I don't really know the numbers in each community, but there's probably at least another 4 or 5 communities that will be going to visit and possibly circling back to Pukacha as well, because that seems to be the main town.
Okay, thank you very much, Carolyn. Carolyn, there are a couple of other questions in the question and answer box. If you're able to, could you maybe type an answer and then people can follow that along? There's a question from Anna Cousins about the protocol for X-ray screening. And I had one final question just about the availability of those resources you've developed. Are they available for other people to utilise or adapt? You know, a lot of time and effort goes into developing resources. I just wonder if they're available for use by others.
I'm not too sure about that. We've just been obviously using them for our visits, and we're working on some more regarding information about latent TB and treatment of that, so that people are aware of the sort of the long-term involvement with that.
Okay, great. And I guess after hearing your presentation today, it's good for people to be able to reach out and speak to South Australian TB Services for further information, or if, you know, they're embarking on other activities that they might benefit from your experience and in your activities. All right, so if we now would like to invite Hannah Ndungu from who's a TB nurse in Central Australia, who'll present a case highlighting the specifics of contact tracing and TB management, especially among Indigenous communities in Alice Springs. So we'll hand over to Hannah. Thank you.
Hi, my name is Hannah. I'm just going to talk a little bit about TB here in Central Australia. I have with me Dr. Belinda, who is going to support me to answer some of the questions. So just a little acknowledgement of country. Tanya, you have my slide, so I'll just tell you next, so you can go to the next slide. Sorry, just a second. I'm trying to, my screen has hung. Yeah. Sorry, just a second. So I begin today by acknowledging the traditional custodians of the land that we stand on today, the Aranda people. We pay our respects to the elders past and present. We extend that respect to Aboriginal and Torres Islander people here today. Next. So that's just a photo of Central and Barkly area. Central Australia covers around 546,000 kilometers square, with a population of around 40,000, 43% being Aboriginal people. We've got one hospital with 2,207 beds, one CDC unit, and one TB nurse. So just to also highlight that the Alice Springs Hospital also services most of the remote communities surrounding the NT. That's inclusive of the APY lands and the NWA. So we liaise a lot with these other community services. And that's also just a little photo of where we currently sit. We sit here in Alice Springs, in separate from the hospital, in Yulipa House. So in the NT, public health units are responsible. Oh, next slide. In the NT, public health units are responsible for TB control activities in the region. Each unit is responsible for all activities, including screening, case management, contact tracing, and disease notification. And the CDC has established some guidelines for the control of TB in the NT, to include that you have to have a negative smear to leave hospital isolation. And MAN2 is the preferred test here in the NT. And we do direct observation treatment until completion of treatment for every active patient, and sometimes some latent TB patients, and treatment and follow-up for all latent TB patients. Next. So I'll just talk about one of our cases, our active cases. She's a 63-year-old. She was admitted in January 2023 and discharged in March 23rd this year. She came in referred by the Aboriginal Medical Services with septic shock and multi-organ failure requiring intubation for agitation and also to allow for provision of care. A bit of past medical history. She had CKD, type 2 diabetes, hypertension, cirrhosis, excessive alcohol intake, and latent TB. So her TB links was that she was a close contact when she was 7 years old. Both of her parents had active TB treated. She was also treated for latent TB. This is back in the 1960s with isoniazid 100 milligrams. She's also got a lot of travel in between states. She is from the APY lands originally, so she's got a lot of family in the APY lands. Next. So just some of the challenges that we had while we were taking care of her. One thing is that our sputum smears are processed in Darwin. That's 1,500 kilometers away. So if you collected a sputum on Friday, you probably expect to get the results on Tuesday. Contact tracing, also amikacin levels. So she had a quite complicated, so treatment, first line treatment was contraindicated due to significant liver and kidney impairment. So she had been commenced on an amikacin. We had to send the levels to Adelaide, which had a 5-day turnaround. So we had to cease that and recommence on other medication. Contact tracing was also not the easiest. She had to be intubated for a couple of days because she was incoherent, and she was also incoherent. She was also living in between town camps. Her contacts were also highly mobile, so it was really hard to establish who was a household contact, and it proved to be very labor intensive. Also, MAN2 readings were not the easiest. Going back to do a second MAN2 and just to do the readings was not easy. We also had the difficulty, because this is during COVID, peak of COVID, trying to explain that MAN2s were just not cheap. So it was not the easiest. We also had a bit of communication barriers. Most of our clients do not have mobile phones, and if they do have mobile phones, they keep changing their numbers, and sometimes it's prepaid, so they're not able to contact us just to let us know whether they've moved or where they are. Next slide. Now, I thought I'd just mention a little bit about the town camps and what they are. So there are 18 town camps in Alice Springs, and they're Indigenous owned and run. The town camps were established back in the 1970s to provide a place for Aboriginal people visiting from remote areas where they could stay for short periods, and they could stay close to family and work and also get some rations. Over time, people have made the town camps their permanent homes and have lived there for over a few decades. So that photo just shows the various places where the town camps are just around Alice Springs. So Alice Springs is smack in the middle of the town camps. Next slide. So we had to work with every other service to support our client. We worked with Nanapa Health because our client travels a lot in between Alice and the APY lands and Amatar just to get her medication. So Nanapa Health has been very helpful with that. We had to allocate her a permanent house in one of the town camps. Also, she needed a lot of home supports to include showers, shopping, and laundry. She's got podiatry review because during her treatment, she had dry gangrene of both of her feet. So she's got a lot of services surrounding her. I feel like every day she has something happening in her life. Also, we have monthly ECGs and bloods, and ID reviews her monthly. Next slide. So in general, there are a few barriers that we encounter during our management with TB patients, one being geographical barriers. As you can tell, we cover a really large area, and it's not the easiest to access some of our clients, and some are situated very far away from the specialized health services. Also, we have cultural barriers where this is modern medication versus cultural medication. So trying to convince our clientele that they need to have their treatment and that what the treatment is. Another barriers is that we have socioeconomic disparities. There's a large lower socioeconomic status, which leads to reduced access to healthcare resources. So they don't have, some of our clients don't have transportation in between to town and to some of the health services. Another thing is that we've got a bit of language barriers. So there are very many languages in Central Australia, and it's not usually easy to also communicate. Another barrier is migration and mobility. Most of our clients are very mobile. They are hardly ever in one place. They are constantly traveling in between town camps, in between communities, and also in between states. Another thing is that we've also got competing priorities. So sometimes healthcare or taking your medication is not usually a priority. So sometimes they want to go out to other communities, and you have to chase them up, or maybe when they're going for soaring business, and you have to just find a way to work with other services to ensure that our clientele gets their medication. Dotting, contact tracing, it's very labor intensive. And also we've got some competing healthcare priorities. Next slide. So what are our workarounds around it? So we have Aboriginal liaison officers, ALOs, like we like to call them, and AHPs that sometimes they usually accompany us to visit some of these town camps, some of these communities when we're going for a DOT therapy. They help us navigate some difficult situation, like sometimes walking into a sorry business where you were not aware that was happening, and they've been very helpful. Also liaising with other health care services, like the AMS, the Aboriginal Medical Services, also Nanopa Health. They've been such a, they've provided a lot of support in the care of our clients. Another thing is incentives. So we do provide incentives where sometimes we provide food, organize the client's electricity, sometimes organize some rides to town just to get them to take the medications, just to comply with that. Also, there's a bit of enabling where we have, when we're giving DOTs, we have to agree to come back, maybe come back to also when they're not happy to have the medication, maybe they're asleep, and they ask us to come back maybe after an hour to give the medication. All these are things that we've been using to help patients adhere to their medications. Next slide. In summary, management and control of TB in the NT has been successful, as there's been a decline in TB in Central Australia. So we attribute it to dotting the active cases until they complete their treatment. And as you can tell from the graph, so we've got, the first one is just TB notification by ethnicity. So we've got the overseas in blue and Indigenous in orange and non-Indigenous at the bottom. And just the yellow line is the total. As you can see, most of our TB cases are overseas. Also, the next photo just shows the incidence per 100,000 in the NT, and you can see there was a huge decline of TB cases from 2000 to 2006. Another thing that we attribute is our contact tracing. We are very proactive in contact tracing. Our current case had more than 100 contacts, and we had to go through each contact, do their MAN2 testing, and just a lot of follow-up. And we also attribute this also to TB sitting in the public health unit, because that really enables us, like with contact tracing and providing these services. Yeah, thank you. I'll just ask you any questions. If you have any questions, you can direct them now.
Thank you, Hannah. There's a comment from Evan there. It sounds like you're doing a great job, Hannah, in difficult circumstances. Thank you very much for the presentation and overview. There's another question about how do you manage DOT, contact tracing, and general patient support with only one TB nurse?
That's a good question. So, so we've got, so when in the public health unit, we sometimes borrow the nurses from other services to help us with contact tracing. And also, like I said, other services like Aboriginal Medical Services have been very helpful in that. And the ALOs, it is a challenge, but we get there.
Okay, great. Are there any final questions? No, if not, shall we introduce our third speaker? Thank you very much, Hannah, for that.
Thank you.
Okay, so our third speakers are Catherine White and Gemma Devlin from Queensland. Catherine and Gemma are going to present on utilisation of the Queensland Public Health Act in coordinating TB treatment in an actively infectious case. So Catherine is the clinical nurse consultant in the Metro South Clinical TB Services in Queensland. Gemma also works for Queensland Statewide TB Services. So we'll hand it over to Gemma and Catherine. Thank you.
Hey, how you going? Can you hear us okay?
Yes, we can hear you.
Yeah, well, good. I'll say, well, it's still slightly morning for us, so good morning. Thanks for having us. I'm just going to see if I can arrange this share screen. Just bear with me a moment. Is that working?
Yes, we can see the screen. Go ahead.
Perfect. So today, Catherine and I will be talking about, apologies, our pictures aren't quite so picturesque as the previous ones. So we're just talking about utilising the Queensland Public Health Act and coordinating treatment for an infectious patient we had that was not complicated, but certainly did present a few issues for us here in Queensland in the Metro South area. So first of all, just wanted to take the time to acknowledge the traditional owners and custodians of the land which we're all meeting today, wherever that may be, where you are. Pay our respects to the elders past, present and emerging, community leaders, and in Brisbane that's the Turrbal and Yagara people, and we also extend this respect to Aboriginal and Torres Strait Islander peoples joining us today and recognising the constitutional of cultural, spiritual and educational practice of First Nations peoples. So just to move into the case presentation, Kat's going to talk to this.
So this was a 28-year-old young male who arrived initially as a refugee in 2000 from sub-Saharan Africa. In January of 2015, he presented with productive cough, fevers and weight loss from of over 10 kilos over a 12-month period. And he also experienced some left side pleuritic pain. X-ray was done and it was obviously suspicious for pleural effusion. And this was confirmed as MTB, and there was no pulmonary involvement at this stage. Unfortunately, this gentleman was rather difficult and challenging to locate, whilst he was not only an inpatient, as he did abscond rather frequently, but he also did have a history of incarceration. So we had no fixed abode, and it was noted also as alerts that he had occupational violence and antisocial behaviour. And there was, unfortunately, some of our colleagues received some injuries due to some assaults as well from this gentleman. And also, this gentleman was rather not willing to answer any particular questions in regards to any past drug use or alcohol use, even though there was a relationship with ATODs at the time. So following his initial diagnosis in January, we commenced directly observed therapy at the TB campus here at the Princess Alexandra Hospital, and he attended for 4 days. During this time, he had reported that he didn't have any money, that he also didn't have any home, and he also did report some complaints of initial itch and rash on arms. Pardon me. Unfortunately, staff did experience personal threats to themselves and also to their family, and the relationship between the nursing staff and the patient did deteriorate rather significantly because of those threats that were quite violent in nature. It was then decided that therapy would be withheld. In the interim, there was a lot of communication going on between multiple organisations. So this being the team within the prison system, there was Employment Plus and also Centrelink. And continuous attempts were made to also engage and bring this gentleman into the TB clinic. In March and July, we received a phone call from the Queensland Police Service advising that they had picked up this gentleman and he was about to be incarcerated. We were fortunate though, whenever he was actually picked up with the other, the QPS, that he did always report that he had a condition being pulmonary TB and he was a risk and infectious to others. And during this stage on point of being in the watch house, we were able to actually obtain a couple of sputa, which did prove that he was smear and culture negative at the time. We then also received further confirmation from the QPS that in November he had been permanently incarcerated, and then on review from the within the prison system, it had been found that the pleural TB had spontaneously resolved. So there was no other current evidence of active infection, and unfortunately we had to record his treatment at that stage as being a default.
So this slide is really just to give you an idea, a bit of a timeline for that particular presentation. So he presented with the pleural effusion with no pulmonary involvement. He attended 4 days of that DOT, but then failed to attend any further appointments or attendance for DOT. And the spot sputas that we were able to obtain were smear and culture negative. So really had that ongoing assessment of his pulmonary and infectious risk. And then radiology showed that that had spontaneously resolved. But as you can probably expect, that wasn't the end of the story for this gentleman. So in August, we heard him again.
We did. So we were informed by the emergency department at another major hospital in Brisbane that he had represented to ED following some violent, unfortunate episodes. And there was an incident or finding on radiology that he had obviously had highly suspicious nature for active pulmonary TB. Fortunately, we were able to obtain a spot sputum, which actually did have evidence of that he was smear 3+. This did culture, and we were fortunate that it was fully susceptible. There was also evidence of bilateral cavitating lesions with opacities and nodular airspace consolidation. Unfortunately, this gentleman did again abscond later following the sputum being actually obtained. And this led to multiple challenges that will now lead up to the next slide that Gemma will discuss. So there was multiple attempts from the TB service to try and locate and contact this patient through IMR and through past notes that we had had of this gentleman, and through utilising multiple services of Centrelink, his GP that was known to us, ATODs, etc. We had visited his parents' home, his partner that was known to us at the time, and any other associates that we knew to have been involved or who had visited this gentleman while being admitted onto the ward and prior to his absconding. We did make a formal decision that while it wouldn't be routine, we did make a decision to actually have 2 nurses be present on all of the attendance of home visits. And of course, that's because of risk assessment with any behavioural or physical hazards that may in fact be there. We were fortunate that on attendance that, as I'm sure you can appreciate, there was some rather seedy premises that we had to go to. Most people were actually quite willing to engage and try and assist us without us providing overly too much information, but there was obviously concern that this gentleman, even from their perspective, was not particularly well. So there was lots of going to hotels, to parks, and to obviously a number of other places. And so we did have to also engage multiple stakeholders as well, as previously mentioned. When contact ultimately was made with this patient, there was a number again of some other personal threats that were mentioned. That this person had done to other nurses, and we were not particularly able to engage or encourage this gentleman to attend our service, and communication sort of broke down a little bit then with this patient, unfortunately. And ultimately a decision was made to move to a public health order due to the risk to public safety. And this was due to multiple meetings with our executives, our communicable diseases network, our treating physician, our case managers. There were multiple people who ultimately made the decision that a public health order may in fact be the best of interest for this gentleman and for public. Jen.
So this slide is just to give you an idea of the relevant section of our Queensland legislation, the Public Health Act 2005, that relates to applying for a public health order for a controlled notifiable condition. So just to give you a little bit of a snapshot of that, don't expect you to read all of that. However, I'll go through it a little bit more for you. So for a controlled notifiable conditions order, you can either have a initial examination order where someone's detained purely for the medical examination to see if they are a public health risk. There's a behavioural order and a detention order. So the main criteria for a magistrate to order a detention order is similar to a behavioural order in terms of the criteria that must be met. But the main difference is that a person needs to be detained at a stated place for a stated period of time to avoid the person's condition or the condition and likely behaviour to constitute a risk to public health. There can be conditions that are put on this from a magistrate, and it's really up to them to decide what conditions might be appropriate. For a medical examination that requires the person or subject to be undertake a medical examination, it is the doctor undertaking the exam or treatment of the person must give an explanation to them, and the person should get a chance to voluntarily attend or submit for that treatment or examination. And if the person doesn't submit voluntarily, that the doctor may undertake for that, there is a provision on there that force may be reasonable in some circumstances. So this isn't obviously something that is used very lightly for Queensland. Since 2007, we worked out for TB, it's been used 4 times. It really is a last resort. In Queensland Health, the chief executive, being mostly the chief health officer or the Director General, must be satisfied before it even goes to a magistrate that there is a controlled notifiable condition, there is an immediate risk to public health, and that immediate risk hasn't actually been tested in the court, so it's really up to the team to identify like what that immediate risk means, and really have to have a clear idea about where that person's going to be detained and what the plan is for them, and it really need to show what those reasonable attempts and other alternatives attempted are. So obviously within this case there's a lot of briefs, a lot of meetings with hospital board management, executive teams, chief health officer, the legal teams within those areas, and obviously in TB we're in the long game, so we would prefer not to use this because we need to really get people on board for long periods of time to be able to really commit to their treatment and really see it through, to gain trust for contact tracing. So, you know, this order provides 28 days detention plus 1 extension of 28 days. So it is a small snapshot on someone's ultimate full TB treatment. And thankfully, this was fully susceptible, but would have even been a longer journey had that. So, you know, as a requirement of this, the doctor has to provide an affidavit, and there needs to be someone to serve this to the person should they be able to locate them and it's not an infectious risk. So, yeah, sorry, I just spoke a little bit about how you make that detention order and about the immediate public risk. And it's really up to us to provide all that information to a magistrate so they can really make a circumstantial decision on that case. And so as much information as we can provide in the most concise manner. And we don't want to be wasting a magistrate's time either. So, you know, really getting all our ducks in a line and getting that right, but within a really fast time frame as well, because we really are concerned for this patient as well, who is quite unwell, and the public. So this is just a little timeline to give you an idea. Once the public health order was provided, I'll let Kat explain how the treatment went from there.
So fortunately, the public health order was granted and we had the initial 28 days in hospital for treatment. And then we had a further extension of that 28 days. So we thought, you know, the TB gods were definitely looking after all of us, I think. On the ward, while this gentleman was there, there were, of course, multiple daily visits that occurred to assist with building up that rapport with that patient and also with the nurses involved. An escort was always present, and unfortunately, due to the patient's past incarceration and dealings and rapport with police and those in security, etc., he was rather quite apprehensive to have anyone else within the room. Pardon me. Ultimately, this gentleman was discharged once we ended up having a culture conversion on the 31st of December. While we had him coming in initially for 5 days a week through lots of assistance with taxi vouchers and assistance to and from the clinic, we did have to have security in attendance. Ultimately, this gentleman did start to, at times, not come in throughout the Monday to Friday period, and that would be because of the security. So we had an agreement that the security would be in attendance at the TB service during certain hours of the day, but this gentleman at times would rock up, you know, just as we were closing doors or way earlier in the morning before even staffing would actually be fully present. So the plan throughout this process was to do a thrice weekly therapy for Monday, Wednesday, Friday. And initially, if this gentleman was to present even 2 days in a row, for example, Monday or Tuesday, and then attend on a Friday, at least that we knew that he was obtaining those three doses.
Thanks, Kat. And I just thought I would add, once the public health order was approved by the magistrate, in order to serve that, it was going to be a little bit complicated in terms of having an environmental health officer from the public health unit, the TB consultant, with QPS to try and locate him. But for some stroke of luck, he was picked up by the police and told them that he had TB and was actually taken to another health facility on that very same day. I don't know how at the time, but on that very same day. So he was able to be directly admitted to the hospital for that treatment. So I've just got a slide here. I'm sorry if it's not that clear. I did have a play around with how I could best highlight the dates. So apologies, I spent too long on that. But essentially you can see that the green highlighted is the days he actually attended over that 9 months. And it really was a little bit random, sometimes a couple of days in a row, sometimes one day, sometimes not a particular week, not any particular pattern. So he was admitted for that 56 days, but then discharged. And Of course, we had a great plan. However, we had to keep moving that and be flexible as we are in TB, and we really had a change in the regime a couple of times due to weight gain, but also to try and make sure that he had the longest acting treatment as possible, given that there were a number of missed dot opportunities. And also, I think even in that first week of January, he was served with a letter to say that he wasn't complying with his behavioural order. However, I don't think that actually had much traction.
No, I believe, I agree. I believe he may have received a fine, of which, he didn't really think much of, unfortunately.
So yeah, I guess for me, it really highlights, yes, he had that 56 days admission, which is really great to get him culture converted, but thus still maintained. The nursing team tried really hard to keep him coming, to try and be flexible. I mean, initially we offered to go out and do DOT, but obviously with the safety concerns and things, it wasn't a possibility. But however, he did have the taxi vouchers to and from, which he seemed to utilise a lot.
Yes.
To various locations. And this is just a little graph of the days attended to not attended.
And thank you, Jim. And in August of 2019, there was success. We ended up finally having a sputum that was smear negative and culture negative. Radiology report indicated that the pleural parenchymal fibrocalcific change in lung capacity apices bilaterally stable, and there was no consolidation seen and no active disease seen. On the last day that he actually attended for his dose, there was cheers all around, inclusive of the patient, and in fact some of the staff did in fact get little hugs from this gentleman, which did put a smile on your face. It made everything worthwhile, the 3 years basically of progression with this gentleman.
So I think this, for us, this case is just a really good indication of, the relentless follow-up. Even in the time between the pleural effusion in that first presentation, the case nurse actually had this gentleman on their books and was really sort of still trying to make contact and making sure there was no respiratory signs and things, and really continued to try and make contact with this patient throughout that 3 years, even despite the personal threats to themselves and the family. And I just think it's a really good example of how us as TB nurses, we just can see the bigger picture and do have to be flexible with our thinking. And then I think it's also highlights, the importance of follow-up support and welfare of staff. We had a number of debriefing sessions relating to this particular patient, and people really needed close support, particularly after some of those threats. And we even had to remove people from managing this case because it was too much, but we had to try and keep try and keep some consistency for the patient in terms of who he was dealing with, but also, really keeping an eye out for staff. And obviously the use of the public health regulation and the public health orders is one piece of the puzzle. And as I said, we're in there for the long game. So we really, despite all those things throughout that, continuing to go and see him on the ward to build that rapport, and when it can, just try and make it, yep, we're just about to close the door. Okay, what can we do for you? Let's just try and make it as simple as possible, and try and make it as smooth as possible.
Sorry, Jim. Wouldn't answer any phone calls. He wasn't at any premises. And even with the follow-up and trying to chase up on the home visits of where exactly he may or may not be located, it was decided then that basically we'll stop the treatment.
And
And
I
just-
think, you know, just coming back to that public health order, we really couldn't say whether that person was an infectious risk because they were, there was no pulmonary involvement, and there was, you know, we had those ongoing spot sputums. So it was really difficult to prove that there was an infectious or immediate public health risk, which is why we couldn't go down that path in the first instance.
And all the sputers were smear negative and culture negative.
And were you able to do any contact tracing around this fellow?
We had 3 people that we were able to contact trace, one being a partner of this person, and everyone thus far was smear negative. However, there is obviously a concern that this gentleman, especially while he was infectious, we are waiting potentially to see, you know, in the next couple of years if anyone else may in fact develop disease.
Certainly while he was incarcerated, we had a pretty good communication line with the medical officers and the nursing staff in corrections, and they were able to really keep an eye on if there are any respiratory symptoms, and that's something that, that we were keeping that line of communication open, even when he sort of wasn't technically on treatment.
And in the initial bolo that we had in 2018 prior to his readmission, being on the lookout for, we did advise that infectious precautions were to be utilised. If he was incarcerated, etc., please wear a mask or isolate him until opportunistically spits.
But his contact tracing was, and like interview for that, it was limited, and it also was pieced together over that 3 years.
Mm-hmm.
Yeah.
Well, that's very interesting. So thanks to both of you and to all our speakers. I'm not sure if there's any other questions. Please put them in. So we've had about 83 participants, I see, and I know multiple people are listening on the one screen. So I think we had about 100 or 90 people say they were coming. It's not often we get such a high success rate. Usually we accept about a 30% of people show up as a victory. So it just shows how much interest there is. And I'm sure hopefully people take away a lot more questions, and maybe people get in touch with each other. And so certainly as a TB physician, I'd like to thank all the nurses and public health nurses who do such a great work and really the backbone of this, of all the programs we've heard speaking from across Australia. So I'll just hand over to Amanda just for a closing comment.
Thanks, Andrew. I also want to note that having 82 different groups join shows a level of interest, and thank you very much to ACTnet for giving us the opportunity to get together today. We've had 3 great presentations that show very different perspectives on the work of TB services and nurses across Australia. So thank you very much, and I hope that we can repeat this next year or in the future. It's great to hear the work that everyone's doing and share expertise and wisdom. So thank you to our presenters, and thank you for everyone joining today.